thank you for the opportunity to speak to you about a topic that both Jim and I feel very passionate about, and we've had some opportunities at UCSD to really innovate in this space of emergency care for seniors. I'm going to take the first half of the talk, and then I'm going to turn it over to Jim and really talk about our experience in San Diego in terms of what we're doing for seniors. So you're all aware of this baby boom that's coming. Actually, it was a few years ago that really the retirement, that the first baby boomers actually hit the age of 65. And it's going to be if you look at the data, it's here, right? So if we look at 2020, where we're just about there, we are actually at the steep part of the curve. Ultimately, we're going to hit 25% of our population is going to be over the age of 65. In 15 years, that population will be larger than our population under the age of 18 in this country. And if you look at worldwide statistics, this trend is even greater in the developing countries. So there's, it's happening throughout the world. So this is coming. It's actually here. We're here now, and we need to prepare for the next 10 to 20 years. So just by statistics, by 2060, nearly 100 million individuals will be seniors in this country. It'll triple the use of hospitals and emergency departments, and from our standpoint, over 21 million visits will occur in the emergency department. That's virtually one visit for every 2 seniors every year that will come to the emergency departments in the future. And it's already overburdening the healthcare system, as we know now, and we see it in our emergency department here. I'm sorry, we're bombarded with aging boomers. Come back in 20 years. So our national professional organization, the American College of Emergency Physicians, as well as our Nurses Association, as well as the American Geriatric Society, saw this. And so a couple of years ago, they came out with some guidelines around emergency department for seniors. They call them geriatric emergency department guidelines. There has been a trend for a lot of emergency departments to say that they're geriatric emergency departments, and there's been a lot of pushback on what that really means. And so these organizations set up some guidelines. They actually set up an accreditation system, so similar to trauma centers and pediatric emergency departments and cardiac receiving centers. There are now specific policies and procedures and protocols and guidelines that need to be adopted. And much of this work was done by 2 foundations. John A. Hartford, you've probably heard of that. It's focused a lot on geriatric and senior care. And then the West Foundation, which happens to be in our backyard, which was fortunately very fruitful for us in terms of our collaborations in this space. So is it really different? Because somebody asked me once, so shouldn't this, we were described what we do, and somebody said, shouldn't you just do that for everybody who comes to the emergency department? And they're undoubtedly correct. But we don't have all that. It's a resource-intensive process, and so we can't do that for everybody. But if you look at preliminary data on some of the things that we're going to talk about, there has been shown some early ability to improve the outcomes for patients, to actually lower their return ED visits, to lower their immediate 30-day hospitalization rates, and to really improve the transition to care and lower costs. And we are actually seeing some of that in what Jim will talk about in a little bit. So, as I mentioned, the Wests are our neighbors. They're literally across the street from the general campus, and we were able to get some money out of them to actually fund our unit. And when we look at the unit that we built, it's really, I'll talk a little bit about the environment, but it's really about the people and the process of how we take care of patients in the emergency department, and then some of the technology that we've been able to utilize and take advantage of. Our emergency department was actually featured. This is a full-page deal in the Wall Street Journal last month. We're very proud of that. Emergency rooms get a makeover for the elderly was the title of their article. Jim, I don't know if you want to step in here. This is our transition moment, but this is one of our actual lower acuity rooms for seniors, but you can see there's natural light. That mirror in the back is actually soundproof material, and actually it's a picture of Torrey Pines, which is a state park near UCSD, and it's actually oriented in the right direction. That is, this room is directionally, the picture is actually
geospatially oriented.
Thank you for the technical term. But we'll get a little bit more into the details on the environment. This is one of my favorite pictures because that dark end of the of the hallway is actually where our old ED is, right? So regular patients are being seen there. It's dark, it's loud, it's noisy, and then you walk into the area for the seniors, there's much better lighting, there's less blue light, and some of the lights in the rooms adjust by time of day automatically, so there's hopefully less disorientation for seniors. You can see there's a lot more contrast on the floor and the wall in terms of risk for injury and falls and that sort of thing. So
what we did is we threw out the book of how to make a hospital or make an emergency room, because it's pretty much like a casino. No light. So you have light. So no daylight, no natural light. Yeah. You have lights 24/7, lots of noise, just like slot machines and all the rest. So what we did is we threw that out, and we started off with natural light, as you saw on the prior picture. You had here the natural light. It actually opens up to a nice little garden area where they can actually walk around outside as well. And so we brought in natural light. We turned the light, instead of the traditional fluorescent light, it's now LED programmed for circadian rhythm. So as the day progresses into night, the lights start to dim. Interestingly enough, our artist, who's a local artist, Aaron Chang, who took these pictures, noted that as the day changes, the picture changes as well. So you see the different contrasting colors come out. And so we took that light portion. So our challenge to you as ethnographers, how do we show the value in this? We are trying to study this. We know it works. We know we've had great outcomes anecdotally, but now we want to actually put it on paper. And so what we do is there's different components architecturally in the design. So all of these ceiling tiles are sound absorbers. All of the pictures with the mats are sound absorbers. So the sound is actually focused out of the patient's room. So the patient hears less. It's a quieter environment, more peaceful. All the sound in the hallway here is focused towards the nurse station in the middle here. So if someone's out in the hallway, we can hear from within the nurse station exactly what they're saying.
And the designers put what's known as purple light in the nursing station, right? So that, in theory, supposedly gives staff more energy, right? It disrupts their circadian rhythm, I think, is what they said, right?
Yes, that's correct.
And they put it particularly over the Pyxis station for medication, so they're hopefully making less error. We'll see.
Yeah, we'll see about that. So in the rooms themselves, we designed the room completely different. So you can't really tell on this picture because it's two-dimensional, but right here, this is actually angled out about 15 degrees. The reason for that is to push all of the sound within the room towards the head of the bed. So those that are a little more hearing impaired actually have the ability to hear better. We did that also with the ceiling tiles as well as the pictures here on the side. So all of this sound component goes towards the head of the bed so the patients can actually hear you and not have to lip read. Other components in the room themselves, again, the high contrast color, the non-stick floors, but also little things like a non-splash sink. It all sort of makes a better environment, quiet environment. You'll notice here as well, we also have done away or tried to minimize the amount of wires that patients normally have to get wired up to. So then that way they don't feel like they're tied down. We've created a caregiver space lounge so that family members who are there have someplace to go. And they can sit, they can make phone calls, they can talk about what's going on. Also, they can give the patient some space to sleep.
And give the caregiver some space, because I think a lot of times what brings the patient in is actually the caregivers at the end of their rope. And so.
Yes, and I'll mention that in a second. So what is the process? So the process is really the people. So patients come into the emergency department just like everyone. So they'll come in and they'll get seen by a triage person here. And then they get something called an ISAR. That's identifying seniors at risk. It's an assessment tool that we use. And so that initial assessment tool determines whether they need to go back to the geriatric emergency department section or not.
We had, just so you know, the state has to approve all our plans, and they would not approve a separate entrance for seniors. They said that is too confusing, right? If you put seniors over here for emergency care, people are going to drive by, see it stands senior emergency department. What does that mean versus standard emergency department? So everybody comes through the same, but the EMR actually, once they know the age, it sets off a different set of process for their triage.
Correct. So if the ISAR is positive and they have they call it ESI, but it's a triage level where they're above a 3, then they'll go back to the geriatric emergency department. There, in the EMR, we start to flag our Genie nurse, which is our geriatric emergency nurse initiative expert, which I always forget. And they actually will come and see the patient and do a secondary assessment. And that assessment, I'll go over some of the components of that assessment in just a second. But that assessment happens fairly quickly as soon as they arrive. The Genie nurse has the ability to add consultations to services that are needed based on the assessments.
Either in the ED or as an outpatient.
Yeah, correct.
Right.
And then once that happens, the traditional care still occurs. The patients will actually stay in the emergency department longer rather than get admitted to the hospital. So yes, their stay is a little bit longer in the emergency department, but much less than a typical admission. And so there we can create treatment plans to send the patients home. And those treatment plans can include our projects like Acute Care at Home, where patients actually go home and they get cared for in their home setting as opposed to the hospital setting. Did I miss anything?
I think you covered it.
Okay, so I want to go over some of the data, because one of the things we did is we designed this to actually, let's look at the data as we're building it out. Because we don't know what's best practice. We think we're creating the best practice, but we want to validate that. So in the ISAR, these are 6 simple questions that every triage nurse asks. And so as you can see, you only need 2 of these to be positive. And most things are multiple medications. Am I on more than 10 medications? And so you can see seniors are on a lot more medications than they may necessarily have to be on. The other component is, do they need help at home? Have they recently been hospitalized? So there's a lot of seniors that have had this as they come through. And then, as you can see from our data, over half were positive. So there's a huge component that we hadn't been previously addressing that we are now.
And ISAR has been a tool that geriatrics has used for quite a long time. And it's just never been utilized in ED because we're not really supposed to be focused on that. But if we're actually going to really provide the comprehensive care and reduce their risk for coming back to the ED, these are some of the things that we need to do with this population.
Yes, thank you. So as I was mentioning the Genie, here are some of the screening tools that the Genie will actually use. And so these are all built into the EMR so we can actually get the data components out and use them in real-time reporting for the providers as well as doing consult orders. And so some of these I'll just mention is, mobility, get up and go. How easy is it for the patient to just stand up and take 5 steps? Other ones include both cognitive and dementia, the MoCA score or delirium sort of screening, which is the CAM score. That's done both in the ED as well as in the inpatient side as well. And then also we include elder abuse and caregiver strains. So we're getting the psychosocial components in the assessments. So looking at some of the data that we've already done, our Genie is screened, so out of 2,000 patients, we've had, we've identified 46 that have been at risk. So these are patients that we normally didn't identify that we can now see and say, hey, they need some assistance and or consultations of additional services. And the 2 big ones were nutrition and the abilities to do your L&Ds at home. So can you get up, can you go to the restroom, can you make a meal, those sorts of components. So again, those were identified and we've actually been able to do quite a
Which is interesting, right? Because these are
intervention.
more social determinants rather than actual acute medical problems, right? Nutrition and ADLs, very much
Yes.
social determinants.
So what do we do with the data? So once the Genie has done that, we actually have created, like I said, flow sheet rows. So these are just sort of like spreadsheet components that generate a report for the provider, for the geriatrician, and the primary care physician to say, hey, an assessment's been done. Here are the needs of this individual. We put that into a report and we allow them to actually do the orders all in one step.
I would say this coordination is key, right? Because oftentimes our visit stands alone and it never gets back to their primary care provider. They don't get to the referrals or the consult services they need as an outpatient. And so this ability, EMRs are quite a pain for the other physicians. It's a pain, but this is the one potential ability of being able to move electronic data easily to the right places that helps in terms of coordinating care for these folks.
Absolutely. Being completely transparent for the patient, for the team, and for the family members. So some additional outcome data. So what are they actually, or who are they actually consulting? So on the inpatient side, it could be anyone from our pharmacist to the social worker to a nutritionist, and most times a physical therapist. On the outpatient side, again, very similar, social worker, nutrition, but also to senior medicine. They really need to go see the geriatrician, at least to create a plan for home. And as you can see, this is some of our data that we collected. Yes, they do stay in the emergency department longer. They do get more consultations, but they have better outcomes. We're seeing decreased 30-day readmissions just to the emergency department, let alone to the hospital. Beer's medications, so it's not a beer. Beer's medication is actually a process in which we've identified medications that are at risk for those that are aging. So they may not be able to process the same amount of medication that they did 10 years ago because of their kidney function or for whatever different reason. And so we've created clinical decision support tools to allow and notify physicians in real time, this medication is at risk for this person. Here's an alternative or a lower dose. So not just say, hey, you've done something bad, here's something better to do. Other technology that we put into the senior emergency department is My Bedside Chart. So My Chart Bedside. So it's a tool within our EMR. It allows the patients and the family members to see what's going on in real time. What do I have scheduled? Who's my team? Who's caring for me? What are my results? And so I have a couple of screenshots here. This sort of gives you who I am. So it pulls up the information within the EMR to make sure, hey, this is who I am or my family member. And then also, what's going on for the schedule for the day? I'm supposed to get medications at 9 o'clock. I'm supposed to see an OB person, hopefully not, at a senior place.
That was a unique case in the...
Yeah, quite unique. And then the other part is, who's my treatment team? We've created bios, so patients can actually say, who is this Dr. Chan? What does he do? And then who's the nurse? And so these bios actually go to the patients and they can look at it, and they were quite interested. Opens up new conversations. Other components, our first dip into AI is really with monitoring. So we've partnered up with Philips, who has this biosensor. The biosensor picks up vital sign readings, so heart rate, respiration, body temperature. It also does fall protection as well as geospatial positioning. So that, along with monitoring data, gives us enough data in real time that we can actually start running algorithms on these patients. So are they getting better in the emergency department? Are they getting sicker? Do they have sepsis? Do they have a dysrhythmia going on that we've not caught previously? So it gives us more
without
real-time
wires.
data.
I mean,
without wires.
That's the wireless
So it also
model.
makes them more mobile. And this was our goal, is get rid of the wires, get them up, move them around. The other thing that we did for the room, and you couldn't see this before, but the monitor up here, if I can do this correctly, has a little speaker bar. This is some technology that was developed at UCSD. And what it does is it focuses the sound in 100-degree vertical and about 2 to 2.5 feet wide, all at the head of the bed. And so we have microphones or lanyards that we'll be wearing as treatment team members that'll pick up the sound and push the sound directly at the head of the bed. So you don't need hearing aids. It's enough of the frequency, so it's a perfect conversation. They can completely understand what you're saying. And it's great because if I'm standing there next to the bed, I don't hear any of that sound. So it's awesome. So if the patient's well enough that we can actually send them home, we've started off with some programs called Acute Care at Home. Very, very simple program where, as I mentioned previously, these patients that are what we call low-level admissions, 3 to 5 days, can actually get treated at home. So the home health nurse team that we've partnered with will go and see the patient 2 to 3 times and then use telehealth to round with the PCP or UCSD specialty physician who's caring for them. So this treatment plan actually works great. We've actually, on our pilot study here, these are the most common sort of diagnoses that we had. Most of them were infections. Here's what a DRG is, diagnosis related groups. And so that's what a hospital gets paid for these diagnoses. And so you can see here, I'll just do cellulitis. You have to stay about 5 days and you get about $16,000. By doing the acute care at home, the patient's out cost was only about $1,600 on medium. So there's huge 4-fold, 5-fold savings per patient.
Cost savings,
10-fold
really,
cost savings.
Not great at math, great at technology, not so good at math.
So, but it ranged. So then the other thing is, can we reach out to the seniors before they actually come to the emergency department? And so we did this STAR program with the West Health Group again, focusing on assisted living facilities and opening up the door to assisted living facilities that could be either completely independent or much more hands-on 24/7 care. And so what we did initially is provided unscheduled visits, or urgent, that would be us, or scheduled visits such as a geriatrician, pharmacist, or a geriatric psychiatrist. So the 4 basic sort of care models can be provided in these facilities. We initially started with our traditional telehealth cart. A lot of sort of training there, didn't work out well. So what we did is we changed that into an iPad, and we partnered with TytoCare to provide peripherals to actually do physical exams. And those videos could get pushed to the provider before the telehealth visit, making the telehealth visit much more efficient. This is the breakdown of the telehealth visits. As you can tell, most of the seniors wanted to have a geriatrician visit and actually needed it. So with that, you want to introduce Vaishal?
So Dr. Vaishal Tolia, who's one of my faculty members, is actually the medical director for the senior unit, and he created a little video tour and we'll close with that. It's just a couple minutes long.
Every day, 10,000 baby boomers are turning age 65. And we know that this population, just like the pediatric population has special needs, our seniors have special medical, social, and other needs that we can really address in a unit like this. Earlier this year, we opened the Gary and Mary West Senior Emergency Care Unit for patients over the age of 65 who have a positive ISAR score, which is the identification of seniors at risk. Those patients will be placed into our specialized area here. We can see that this area is different than our current emergency department space. This area is specially designed for our seniors so that it's a comfortable environment for them to actually get their prolonged stay in the emergency department and get their care during that time period. There are several architectural elements that will make it senior friendly. So for example, there are non-slip floors, there is lighting that's circadian friendly so that patients will have decreased interruptions with light and sound. Much of the rooms and the area is designed to be very quiet so that sound does not interrupt patients while they're resting and recuperating here. There's also artwork by Aaron Cheng throughout the space that helps orient people to the fact that they're in La Jolla, in San Diego, and helps decrease agitation and uncertainty. There's also technological enhancements within each room, which keeps patients and their families up to date on the care that they're receiving and the expected treatment plan. We have a nursing team that's very well versed and trained in advanced geriatric care. Specifically, we have a group of GENIE nurses, or Geriatric Emergency Nurse Initiative experts, that are focused on advanced geriatric care screenings and have the clinical decision support tools to actually bring other resources to the patient in the emergency department.
So the first exam we do in triage is called the ISAR. ISAR stands for Identification of Seniors at Risk. This has 6 questions that are a good indicator of whether the patient, the senior, is going to have a poor outcome if we discharge them from the ER today. Such questions as, do they take more than 3 different medications a day? Have they been hospitalized for 1 or more nights during the past 6 months? Or in general, do they have any serious problems with their memory? It also talks about, do they need care prior to coming to the emergency department? And do they think they'll need more care now that they're in the emergency department? So it's a very good indicator of a risk if they are discharged from the emergency department.
Our goal in the senior emergency care unit is to improve transitions of care and to hopefully decrease hospital admissions so that we can give patients what they desire, and that's usually to get home and to get to a more comfortable environment. The research that we're doing is looking at all of these screening tools, looking at innovative models of care, and not only improve the care for our community here in San Diego, but also demonstrate how excellent senior care can be achieved in the emergency department to health systems throughout San Diego, California, nationally, and even internationally, where we can really be the beacon for excellent emergency care for seniors.